Good afternoon, everyone. Welcome to the 11th session of the NHSRC DSP-RED series for implementation of standard treatment guidelines. Today, we will be discussing management of thyroid disorders and screening for
Ma'am.
thyroid.
Good afternoon, ma'am. Am I audible?
Yes, we can hear you.
Okay. Ma'am, our ED ma'am has joined. So she will also address the gathering.
Sure. हाँ.
Yes. So we
कितने
are
बजे
waiting for
आएंगे?
her.
कितने बजे आएंगे?
Sir has talked to her to 3:30 तक आ सकते हैं.
और आप इतना लेट ना बोला करो, सेशन लेट हो जाता है. अभी 15 मिनट में कर लेते. 3:15 बोला करो. हाँ. डॉक्टर पटनी.
एक फोटो खींचो.
डॉक्टर पटनी कितने बजे ज्वाइन करेंगे?
मेरा म्यूट है.
एक से आपको ऑफ करना पड़ेगा, वॉल्यूम वो करना पड़ेगा. Anyway, let me just introduce Okay, I was talking about today's session. Today we will be discussing about thyroid disorders, and we have two eminent experts, endocrinology experts with us. Dr. Ashima Dabas, she's professor at Loknayak Hospital, Manavazad Medical College, and Dr. Alpesh from AIMS. He will be joining us. He will be talking about management of management disorders. While today there was little glitch about this setting up the session today, but anyway we will be starting very soon, and as per the format of the sessions, we have put the link for the pre-test in the chat box. While you are waiting for the session to start, you can start attempting doing this pre-test. As you all know, those of you who have been attending our programs earlier as well, and those who have joined for this session, this pre and post test are just an educational exercises. There we try to portray different case scenarios that we see commonly in our clinical practice. And sometimes if these scenarios are not well understood, or management differs from the standard management, it can bring in irrationalities in the treatment. So we just wanted to assess the gap areas where this variation occurs, and the experts will try to address those gap areas during their sessions. And I hope by doing this pre-test, you will also understand the nuances, although it sounds simple, thyroid disorders, and you know that the levothyroxine is the most of the time it is hypothyroidism, and levothyroxine is the drug of choice. But still, there are many challenges associated with the therapy with levothyroxine. So during these sessions today, we will go through all of these. In the end, I'll be talking about the pharmacokinetic and dosing challenges with levothyroxine so that successfully we are able to treat our patients. Again, those of you who have just joined, there is a link in the chat box. You can open that and start attempting. Once you are finished, then we will start with the session.
I request all the participants to please attempt the pre-test. Only those participants who have attempted both pre and post will get the certificate for this STG webinar. I repeat, please attempt both pre-test and post-test. Only those who have attempted both the test will get the certificate for the STG webinar. Thank you so much. Hello.
For the certificate, as Shreya just now told you, that there is a requirement. Those who fulfill those requirements get the certificate. The requirements are very simple, that you need to attend the sessions. Besides that, take both pre and post test. Sometimes it happens that either you take the pre-test or you take the post-test. Then in that case, you don't qualify for a certificate. So please make sure that you do both pre and post-test and attend through the session. At the back end, we can make out the timing for which you were in the session. So I think if there are any concerns about this, you can write to NHSRC email. There is a dedicated email for this. Ranjit, Shreya, you can put this email ID in the chat box for those
Sure, ma'am. Sure, ma'am.
who want to know about the status of the certificate. And I hope last session certificates have all been issued.
Ma'am, it is yet to be issued.
Okay, so I think many of them are concerned about that they haven't received it because of the festival, days. It has taken some time. So don't worry about this. You will get it. If you fulfill the requirement, you will get your certificate. It will come to your email ID, which you used for registration for this webinar. Good afternoon, everyone. Welcome to the 11th session of the third series of NHSRC DSP RUD series. I hope you're doing the pre-test at the back end, I see only 60 people have taken this test so far, whereas I see there are around 150 people in the room here. Please try and finish this quickly so that we can start with these sessions. For those who have joined late just now, they can find the link in the chat box.
A very good afternoon to everyone. I, Ms. Shreya Srivastav, on behalf of Quality and Patient Safety Division, NHSRC, New Delhi, extend a warm welcome to Dr. Pragya Sharma ma'am, Executive Director, NHSRC, Dr. Rajiv Patni sir, Advisor, Quality and Patient Safety Division, NHSRC, Dr. Sangeeta Sharma ma'am, Professor and Head, Department of Neuropsychopharmacology, Delhi Society for Pharmaceuticals and Rational Use of Drugs, and to all the participants of the 35th session of STG series. I also welcome our guest speakers, Dr. Alpesh Goyal sir, Associate Professor, Department of Endocrinology, AIMS Bhopal, and Dr. Ashima Dabas, Professor Pediatrics, MAMC and Ellen Hospital. Standard treatment guidelines, also termed as clinical guidelines and clinical protocols, are component of health services provisioning to ensure evidence-based medicine and quality of care. At health system level, it helps in planning and costing of services. Standard treatment guidelines also become important tool for monitoring and authorizing procedure in a public funded health insurance schemes. With this quality control, regulatory, and planning functions, standard treatment guidelines become indispensable tools both for public and private service providers. Understanding its importance, National Health Systems Resource Center and Delhi Society for Promotion of Rational Use of Drugs came up with webinar series on standard treatment guidelines as a learning platform for awareness and educating the healthcare professionals across the nation. Today's discussion is focused on detection and management of thyroid disorders. According to various studies, 10 to 12% of the population in India is affected by thyroid disorders. These disorders affect body metabolism, energy levels, reproduction, and bodily functions. Hence, there is a need for awareness so that we can all come up with pragmatic solutions and ways of early detection with management of thyroid disorders. I would request Dr. Rajiv Patni, sir, Advisor, Quality and Patient Safety Division, NHSRC, to please address the gathering. Over to you, sir.
Thank you, Shreya. That is a wonderful introduction to the subject and to the speakers. Uh, Once again, on behalf of Quality and Patient Safety Division of National Health Systems Resource Center, I welcome all the faculty and the participants. It's very heartening to see that nearly 200 have already logged in, and this is despite the festival season which is going on. That shows the popularity of our sessions amongst the specialists and the entire medical cadre. These sessions are beamed nationally, and we have come a long way. Dr. Sangeeta Sharma and NHSRC together, we have worked on this thing, and this is the third year. In fact, we are on the penultimate session of the third year. We are looking forward to planning for the future together. So Dr. Sangeeta Sharma has been a pillar of this program all along. It's always a pleasure to welcome you to the program. It's my honor and privilege to welcome Dr. Pragya Sharma, the Executive Director of NHSRC. Ma'am has just joined, and even though it's not a working day, she has come to office to join this session and encourage and motivate all of us and give us directions for the future. And before I go in, it's my pleasure to also extend a very warm welcome to Dr. Alpesh Goyal and Dr. Dabas, our other faculty, expert faculty for this program. Before we move forwards, it's a quick reminder that quality of care is rooted in evidence-based medicine, in best practices, in medical knowledge that is based on the current professional knowledge. Medical knowledge is changing very fast, and that is why standard treatment guidelines are very important to bring everyone on the same platform. Quality of care cannot be measured without standards, and my division is acutely aware of that because we formulate the policies and the standards for all the quality assessments. So because of the variability in standards, we have variability in the level of care, and that is why the STG guidelines have been, we have been having these webinars. I'm happy to share that more than 12,000 people have already attended our sessions, which is phenomenal for an educational online webinar series. We will be speaking of a very important topic today, which is on thyroid disorders, which besides the physiological and bodily impacts that we see, also has mental health issues. It can also have mental health issues. And I'm very happy that Dr. Ashima Dabas, a pediatrician, has joined us because the root of all ailments can be there from the very beginning. So once again, on behalf of QPS division, I extend a very warm welcome to all the specialists, doctors, CHOs, staff nurses, and public health professionals from different parts of the country who have joined us. And not to forget, of course, my team will be reminding you later, that those who have attended the pre-test sessions and the post-test sessions successfully, they will be awarded a certificate, which will be a digital certificate. We are moving with the times. So after the assessment is over, you will be informed and you'll be able to download your certificates if you have qualified. So thank you very much. And once again, a very warm welcome to everyone.
Thank you so much, sir, for your kind words. With this, I would request our chief guest, Dr. Pragya Sharma, ma'am, Executive Director, NHSRC, to please address the gathering. Over to you, ma'am.
Good afternoon, everyone. So first of all, I want to correct the statement. I'm not the chief guest. I'm the host. for the program that we are doing. And I welcome all the participants, and I'm really grateful that you have taken out time to understand what quality means and why standard treatment guidelines are important. So the division is working very hard in ensuring quality, standards, and certification process, which is going to be going very long way to bring treatment quality at the most peripheral levels. So I congratulate Dr. Patni for his hard work. He's appreciating my presence here in the office, but I would also like to say that he's also here with the entire team, and the entire team is working here on a Saturday afternoon to do this activity along with the experts who are with us. I thank my experts, external experts, Dr. Sangeeta, Dr. Ashima, and I think we have Dr. Alpesh Goyal. So I'm really grateful for you, for you, to you to be here this day in the Saturday afternoon, teaching people at the most peripheral levels to understand what quality means in terms of treatment. I'll not dwell upon the burden of thyroid disorders, which has already been spoken about. So this, what we see is just the tip of iceberg. We have a lot of burden underneath, which is probably not even visible. If NFHS 5 quotes that there are 2.7% of women and 0.5% of men in ages 15 to 49 who have thyroid disorders, there is much, much, much beneath that. And here comes the role of antenatal screening, neonatal screening, and we have Dr. Ashima, who's a pediatrician, who would further talk about it more, and the manifestations of the disease, which will be discussed by the other two experts also. So I'm really, really happy to see this kind of an initiative without actually bothering for a Saturday afternoon or a holiday. And I really wish this a great success. And I wish that more and more people, though we have already covered almost 12,000 healthcare professionals in treating them for, in training them for the standard treatment guidelines, but now we should go wider in spreading the information about such training so that we are able to cover 100% of the primary healthcare facilities and the healthcare providers at the primary level. So I wish you all the best, the quality and patient safety division. And once again, all the best, happy learning to all the participants, and very, very thanks to all the three experts who joined us externally to train our peripheral health staff. Thank you very much, and all the best, Dr. Patni.
Thank you so much, ma'am, for your kind words. With this, I would like to invite our first guest speaker, Dr. Alpesh Goyal sir, Associate Professor, Department of Endocrinology, AIIMS Bhopal. Dr. Alpesh Goyal is a medical graduate with MD Medicine and DM Endocrinology from AIIMS Delhi. Currently, he is an Associate Professor of Endocrinology in AIIMS Bhopal. He is a recipient of several awards such as ESI Yuva Ratna Award 2023, Best Reviewer Award for IJEM 2022, ESI AV Gandhi Award for Best Clinical Research 2018, Shri Mohan Lal Vig Medal for Best Clinical Research 2018, Dr. MMS Ahuja Award for Best DM Student 2018, to name a few. He has over 105 publications in PubMed indexed national and international journals. He has authored 13 chapters in textbooks on endocrinology, diabetes, and medicine. He has further contributed as an expert to the ICMR national guidelines for type 1 diabetes mellitus and the Lancet series on early onset of type 2 diabetes mellitus. His research interests include diabetes in pregnancy, young diabetes, and adrenal disorders. Today, he is going to take up the session on medical management on thyroid disorders. Over to you, sir.
Thank you so much, Team NHSRC, for this kind invitation. Can I start sharing my screen?
Sure, sir. Please. Yes, sir. You can share your screen with us.
It's actually not coming up, so I have to share. I'll try again. sorry, I'm not able to share my screen. Please bear with me for some time.
So there is a share button.
Yeah, I'm doing that.
Okay, I'm trying to share from my end. Okay.
Have you opened your file, Dr. Alpesh?
Yeah, I have opened my PowerPoint presentation.
Then when you go to SharePoint, then you can click on your open file. You will see all the files, whatever you have opened. Then you have to just click on the file.
Yeah, I'm sharing a screen. I'm sharing
No,
entire.
no, don't do that.
Okay.
Then just go to, besides that whole screen, you will find individual files also. Just adjacent, उसके साथ ही दिखेगा आपको. So just click on the file which you want to present and press the share button.
That's not coming up, madam, actually.
Okay.
Yeah, now it has come up. Just
I have shared from my end. Just you tell next. I'll.
okay. Is it visible now?
Not yet, sir. Not yet.
एक मिनट देख लेते हैं, अगर उनके एंड से ही हो जाएगा तो अच्छा रहेगा.
I have shared my screen. Is it visible?
Not yet.
No, sir. Not yet.
हाँ अभी अच्छा नहीं, रंजीत का आ रहा है. हाँ चलिए उसी से स्टार्ट कर लीजिए.
No problem. I can Ranjit, you can share and I can speak through it. No issues.
इसको फुल स्लाइड पे कर दो.
Full slide.
Is it in full screen mode?
Not yet. Ranjit?
Yes, ma'am. Yes, ma'am. We are trying to maximize it.
नहीं फुल स्लाइड वाला. Is there no full slide वो करो, slide show पे जाओ.
No,
Slide
ma'am.
you
Sir
are
has shared
increasing the slide.
PDF में कुछ चेंज कर दिए हैं जिसके कारण से ऐसा हो रहा है.
Oh ये PDF है? No, PowerPoint
No.
है.
It's PowerPoint only.
हाँ तो आप ये स्लाइड शो पे जाओ ऊपर. हाँ इस पे, हाँ फ्रॉम बिगिनिंग. हाँ नहीं हुआ.
Ma'am, we are trying again.
क्या हो गया आज? आप ट्राई कर लो डॉक्टर अल्पेश तब तक.
हाँ जी मैम.
आज तो टेक्निकल वो होता जा रहा है.
Presentation is open. I am
हाँ
going
शेयर
to-
करिए, उसके साथ ही नजर आता है एक. अच्छा अब रंजीत ट्राई कर रहा है.
Okay.
हाँ इसको फुल स्लाइड पे करो. हाँ यार ठीक है. हाँ नीचे जहाँ बटन पे जहाँ पहले था ना, ये वाला. हाँ इसको करो. हाँ क्या हो गया? नहीं तो वैसे ही आप मूव कर देना, नहीं हो रहा है तो फुल स्लाइड पे मुझे भेज दो, नहीं तो I'll run it from my side. आप अपनी presentation मुझे WhatsApp कर दो. I'll run it from here. लास्ट क्लास के अभी तक सर्टिफिकेट इशू नहीं किए हैं. डोंट वरी अबाउट इट बिकॉज ऑफ द फेस्टिविटीज. नहीं हो पाया है. सो यू विल बी गेटिंग इट सून. Okay, I've got it now. I'll share. Yes, can you all see my screen?
Yes, ma'am, it's visible.
Yes, ma'am, it's visible now.
Go ahead, please.
Okay. Good afternoon, everyone. Sorry for the technical glitch. My topic is medical management of thyroid disorders, and I'll try and deal with this topic in following brief headings. Next slide, please. So first, I'll talk about the hypothalamic pituitary thyroid axis, the basic aspects. Then we'll learn about basic interpretation of thyroid function test, because that's something which is very important in clinical practice. We'll look at some case scenarios, and then we look at individual management strategies, clinical pearls for hypothyroidism and hyperthyroidism management. Next slide. So as we understand, the production of thyroid hormones from thyroid gland is regulated by hypothalamic pituitary thyroid axis. So where hypothalamus produces thyrotropin releasing hormone, which acts at the level of pituitary thyrotropes, stimulating them to produce thyroid stimulating hormone, which in turn stimulate thyroid follicular cells to produce T3 and T4 hormone. And these hormones, the end hormones, that is T3 and T4, exert a negative feedback effect on hypothalamus and pituitary. So this is the classical endocrine feedback loop that we also see in thyroid. Next. When we talk about thyroid function test interpretation, the most important aspect to understand is that there is an inverse log linear relationship between free T4 and TSH, such that even small decrements in free T4 are accompanied by exponential increase in TSH, or small increments in T4 levels are accompanied by exponential decrease in TSH. And that's why TSH becomes an exclusively sensitive indicator of hypothalamic pituitary thyroid axis, and it's often considered the most useful screening test in most settings to screen for thyroid dysfunction. So if we have to screen thyroid dysfunction in a patient and we have just a single test available, that is going to be TSH, because any marginal changes in T4 will be reflected with significant changes in TSH levels. And based on this interpretation, we can have several patterns. So you can have patterns where T3 and T4 go hand in hand with TSH. So when T3 and T4 are decreasing, TSH is increasing. This is the concordant pattern that we will expect. Or T3 and T4 are increasing and TSH is decreasing. This is again a concordant pattern that we will expect. But when these hormone tests don't go in same direction, that is T3, T4 are decreasing and TSH is normal or low, and T3, T4 are increasing and TSH is not suppressed, that is when we suspect other problems which are not the routine garden variety of thyroid problems. So let's go to the next slide. So interpretation, you can have low T3 and low T4 with high TSH. Interpretation will be primary hypothyroidism, overt primary hypothyroidism. Normal T3 and normal T4 with high TSH. This is again an issue at the level of thyroid gland. So this is primary hypothyroidism, but of subclinical variety. Low T3 and low T4 with low or normal TSH. This is going to be a secondary or central hypothyroidism. High T3 and high T4 with suppressed TSH. This is again a concordant pattern. This is going to be primary hyperthyroidism. High T3, normal T4 with suppressed TSH. This is again primary hyperthyroidism, but with T3 toxicosis. Now we come to patterns such as normal T3, normal T4 with low TSH. Now this could be a subclinical hyperthyroidism. And then you have high T3 and high T4 with normal or high TSH. This could be secondary hyperthyroidism, which is originating in pituitary, or there could be other differentials. And those differentials we are going to discuss through some case scenarios. Next, please. So these are all the differentials that we generally encounter these variety of thyroid function tests. And of these thyroid function tests, the ones that are labeled as primary hypothyroidism or primary hyperthyroidism, these are the thyroid function tests where we see T3, T4, and TSH moving in the direction that we expect. But when you have secondary hypothyroidism or secondary hyperthyroidism, these are the cases which may be little difficult because their T3 and T4 alongside TSH are not moving in the expected direction. We'll look at such scenarios. Next slide, please. So let's look at the first scenario. So 37-year-old female who has presented for evaluation of fatigue, weight gain, and irregular menses for last 9 months. We know that patients with overt primary hypothyroidism could have these symptoms. And what do we see in the lab parameters? We see that T3 levels are low, T4 levels are also low, but it is also substantiated by low free T4 levels. So you can get low T3 and low T4, but normal free T4 levels in somebody who has binding globulin issues. So it's important to confirm with a free hormone level. And of free T3 and free T4 is more reliable. Free T3 is often unreliable because it is measured in very low concentrations and it is not reliable across immunoassays. So most of the slides that I show, I will keep T3, T4 alongside free T4 and not free T3 because that's not a very reliable endlight on most automated immunoassay platform. And what do we see? Alongside decrease in free T4, there is an exponential increase in TSH to 97. So this means that this is a case of overt primary hypothyroidism. So this is the diagnosis out here. Next. Now, moving to another case, a 50-year-old female who has presented to us with proximal weakness of lower and upper limbs for last 3 years. We know that patients with hypothyroidism can present with symptoms which mimic muscular dystrophy or proximal myopathy. She has facial puffiness, dryness of skin. She has easy fatigability and long-standing constipation. These are again features that could suggest thyroid dysfunction. So a thyroid screen was ordered, and what do we see? There is low T3 and low T4 alongside low free T4 levels. That means thyroid hormone deficiency is there. But we see that TSH levels are not elevated for the degree of thyroid hormone deficiency. Rather, TSH levels are inappropriately normal. So this does mean that there is an issue at the level of hypothalamus and pituitary. And so this is a classical case of secondary or central hypothyroidism. So this is important because secondary hypothyroidism, when it originates from pituitary or hypothalamic area, you have to also look for other hormone deficiency because we know that pituitary houses, apart from thyrotrophs, it also houses other cell lines, which includes gonadotrophs, somatotrophs, lectotrophs, so on and so forth. So we have to also look at other pituitary hormones. So next slide, please. So this is very clear that this is a case of central hypothyroidism because TSH is inappropriately normal or inappropriately low given the low free hormone levels. Next slide. And then we looked back at her history. She's a 50-year-old female. When we look back at her history, we see that she had a last childbirth 10 years back. She had severe postpartum hemorrhage requiring blood transfusion. And she did not lactate her baby and she did not resume menses after that. That means she was secondary amenorrheic for last 10 years. And in face of secondary amenorrhea, what do we expect? We expect a menopausal range, gonadotropins, LH and FSH, but we see that her FSH levels are also normal for her amenorrheic stage. So this means that there is an issue also at the level of gonadotropes. So that means there is central hypogonadism. There is low prolactin level, which contributed to agalactia in this patient, and that is something we can expect in a vascular insult to the pituitary gland. There is low IGF-1 levels, and in face of hypotension, a cortisol level of 8.3 is also low. So this patient has Sheehan syndrome with panhypopituitarism. Next slide, please. So this is the next step was to obtain a MRI of pituitary to rule out any space occupying lesion. And what do we see? We see a partial empty cellular. That is something we expect in patients with Sheehan syndrome. And if we look at her clinical photograph, we see that she has coarsening of her facial features, fine wrinkles around the corner of her eyes and corner of her mouth, and dry brittle hair. And also we see pseudo hypertrophy of her calves along with bilateral proximal myopathy. And this is something which is called as Hoffman syndrome, which is very well described in primary hypothyroidism, but rarely also described in secondary hypothyroidism. So we have seen two varieties of hypothyroidism, primary and secondary hypothyroidism, and how do we interpret them based on a thyroid function test. Next slide. So An important clinical pearl here is that when you see concomitant hypothyroidism alongside adrenal insufficiency, that you would encounter in a patient with multiple pituitary hormone deficiency, like the patient we encountered, or if the patient is having additions alongside primary hypothyroidism of autoimmune variety, you do not start thyroxine upfront. You have to wait. You have to start glucocorticoid replacement first and then followed by levothyroxine, because if you start levothyroxine upfront, it will increase adrenal glucocorticoid metabolism, and this could lead to precipitation of adrenal crisis. So you give glucocorticoids for 2 to 3 days and then add on levothyroxine. And regarding treatment targets in secondary hypothyroidism, it's not TSH. Unlike primary hypothyroidism, where we target TSH, in secondary hypothyroidism, we have to target free T4 levels, because the pituitary is at defect. You cannot correct that defect. You are only replacing thyroxine. So maintain free T4 in mid to high normal range. That's what we do. And always take the sample for free T4 before you take the morning dose of levothyroxine. Moving on to the next scenario. So a 25-year-old female who has presented for an incidental thyroid function test abnormality, which was done on routine checkup. And on examination, she has a grade 1 soft goiter. And what do we see in her thyroid function test? Her T4 levels and free T4 levels are normal. TSH is marginally elevated to 8.2 milli international units per liter, and this test was repeated after 6 weeks, and we see that the TSH elevation is persistent. And at this time we have also done a thyroid peroxidase antibody, which tells us that it is positive. So this becomes a case of subclinical hypothyroidism of autoimmune variety. Next slide. So we have to understand that in this case, we did not label the patient to be having subclinical hypothyroidism after the first thyroid function test, because there are so many other causes of mild TSH elevation other than subclinical hypothyroidism. So for example, recovering from non-thyroidal illness, which we previously called as CQ thyroid syndrome, recovery from subacute thyroiditis, use of dopamine receptor antagonist, obesity, adrenal insufficiency, they can also be associated with mild SCH. Aging is also associated with increase in TSH levels normally. So after age of 60 years, your upper limit of reference interval is patient's age in decade divided by 10. For example, for a 65-year-old individual, the normal TSH will be up to 6, not up to 4.2. So there could be assay interferences or other differentials for a marginally elevated TSH, and that's why it is important to repeat TSH and label subclinical hypothyroidism. Next slide. Next slide, please. So diagnosis of subclinical hypothyroidism is confirmed on 2 thyroid function tests, which are performed 2 to 12 weeks apart. And when to treat subclinical hypothyroidism, either the TSH is more than 10 milli international units per liter, when we consider it to be an overt hypothyroidism, or TSH is marginally elevated between 4 to 10, but patient is pregnant or is planning pregnancy. Patient is thyroid peroxidase antibody positive, because these individuals are more likely to progress to overt hypothyroidism. There is presence of goiters. There are multiple CV risk factors or frank CVD is present. Or if patient has symptoms and signs of hypothyroidism, where a trial of thyroxine can be given. And if after 3 to 6 months there is improvement, you can continue. If there is no improvement, you can stop the treatment. Next slide. Moving on to the next case scenario. This is a 16-year-old female who has neck swelling for last 6 months associated with weight loss and hyperadrenergic symptoms. With hyperadrenergic symptoms, I mean palpitations and tremors. She has grade 2 goiter, coarse tremors on examination with tachycardia and warm extremities. When we see her thyroid function test, we see that T3 is elevated, T4 is also elevated, and TSH is suppressed appropriately. So this does mean that thyroid gland is producing more hormones, and this is suppressing the pituitary. So the axis is working as it should. So this means that the problem is primarily at the level of thyroid gland. So this is primary hyperthyroidism, or we can say thyrotoxicosis, primarily of thyroidal audition. Now, in this patient, we performed a technetium 99M thyroid scintigraphy. And this, we know that the thyroid scan is used to delineate the etiology of hyperthyroidism, whether it is a thyroiditis or it is a hyperthyroid Graves gland or a multinodular goiter. So on the left side is the normal gland, where you can see that the tracer has uptake in the salivary glands and within the thyroid gland, within the thyroid bed. But in this patient, what we see that there is intense uptake in the region of thyroid gland, but there is no uptake in the region of salivary gland. So this is a classical a diffuse thyroid gland that we see in patients with Graves' disease, and this was also substantiated on TSH receptor antibody titers that were elevated in this patient. Next slide. So another case scenario, 40-year-old male with thyrotoxic symptoms for last 2 months with history of weight loss. Now you see the history is shorter in this case. It is of a shorter duration as compared to the last case. Patient has tremors, tachycardia, and alongside that we see that there is tenderness in the region of thyroid gland, and patient has elevated ESR and elevated total leukocyte count. So that does tell us that there could be an inflammatory pathology within the thyroid gland. And when we see the thyroid function, we see that T3 is high normal, but T4 is elevated. And that is something that you expect when there is destruction of the thyroid gland, because thyroid gland predominantly contains T4, the secretions predominantly contain T4, and that's why that there is T4 predominance in this case, and TSH is suppressed. So our clinical diagnosis here remains subacute thyroiditis, but this needs to be confirmed. And again, we did a thyroid scintigraphy. And next slide, please. And what do we see on thyroid scintigraphy? Again, left side is normal, I've already explained. And on the right side, we can see that here, as opposed to the previous case, there is good amount of uptake in the salivary glands, but reduced uptake in the region of thyroid bed. That does show that the thyroid gland is not taking up the technetium 99M tracer, and this is something that is supportive of subacute thyroiditis that was also clinically corroborated. And TSH receptor antibody titers, again, these were not needed, but they were performed, but they were negative in this case. So this does tell us that this is subacute thyroiditis, and it is important to differentiate between the two etiologies, because a thyrotoxic biochemical picture does not mean starting antithyroid drugs. This patient with subacute thyroiditis only requires close observation, treatment with beta blockers for symptomatic relief, and this condition will spontaneously resolve. If given antithyroid drugs, this patient will end up in iatrogenic hypothyroidism. Next slide. So these are broad points of differentiation between subacute thyroiditis and Graves' disease. Short duration subacute thyroiditis versus long-standing history in Graves' disease. Presence of other autoimmune diseases favors Graves' disease. Presence of orbitopathy or dermopathy. If patient is having significant orbitopathy or dermopathy, you don't even require a thyroid scan or TRAB antibodies. Presence of thyroid tenderness in thyroiditis, course being self-limiting versus progressive, presence of TRAB antibodies or TSH receptor antibodies in Graves' disease, and the radioiodine uptake pattern, which is diffuse versus decreased in subacute thyroiditis. And the treatment I've already discussed. You treat symptomatically in subacute thyroiditis, and you give an antithyroid drug course at least for 12 to 18 months in patients with Graves' disease. Next slide, please. So different patterns of uptake on thyroid scintigraphy, diffuse uptake in Graves' disease, patchy nodular uptake in toxic multinodular goiter. In an autonomous functioning thyroid nodule, you can get a single area of nodular uptake with surrounding cold regions. And in subacute thyroiditis, as we have discussed, a reduced uptake in the entire thyroid bed. Next slide. Next case is about a 23-year-old female. She's a primigravida. This is her first pregnancy. She is having hyperemesis symptoms, and these symptoms we know are related to SCG, and these are prominently present between 9 to 16 weeks in most pregnancies. And her TFT is done at the 10 weeks period of gestation, which shows a suppressed TSH and mildly elevated T4 levels. These T4 levels are still elevated for even for a pregnancy. Even for pregnancy, I will discuss that. She does not have any signs of toxicosis. There is no goiter. Her TRAB antibodies are negative, and this is a classical case of SCG mediated thyrotoxicosis, because SCG shares alpha subunit with the TSH, and it can stimulate TSH receptor. And this is a common source of consultation in endocrinology. And this can be dealt with at the local level only, that during this period, between 9 to 16 weeks, there is often a tendency for HCG to suppress TSH. And these cases require supportive management and close observation. They don't require institution of antithyroid drugs. Next slide. So gestational toxicosis, what I have discussed in the previous case, it is SCG mediated, typically presents between 9 to 16 weeks. You don't see other autoimmune diseases which can be concomitantly present with Graves' disease. They don't have orbitopathy or dermopathy. It's very self-limiting. It resolves over a period of 6 to 8 weeks. TSH receptor antibodies clinch the diagnosis, because in this case you cannot do a technetium scan as the patient is pregnant, and treatment is observation. It's just you require some supportive treatment. Next slide. Now, seventh scenario is a 62-year-old male who has presented to us for an incidental thyroid function test abnormality, which was he underwent a routine checkup. And what do we see here is that T3 is mid-normal, T4 is also mid-normal or just high normal, and free T4 is in the high normal range, and TSH is suppressed to less than 0.1. So this is a setting for subclinical thyrotoxicosis. So this is something that we can encounter in several age groups, but when it is present in elderly individuals, we are more skeptical, because low TSH per se can predispose them to osteoporosis and atrial fibrillation or cardiac diseases. So next slide, please. But we have to understand that, again, just like subclinical hypothyroidism, there could be other causes for low TSH other than subclinical hypothyroidism. As we have discussed, pregnancy can cause a low TSH individually through SCG. You can get low TSH in non-thyroidal illness. Use of dopamine and glucocorticoids, especially in ICU settings, you can get a patient who has low TSH levels. Then if you are treating a patient with Graves' disease with antithyroid drugs, T3 and T4 may normalize and TSH may remain suppressed for a long period of time. And that is something which can again give rise to low TSH with normal T3 and T4 levels. So it's important to ask if patient is taking any antithyroid drugs. Similarly, levothyroxine exogenous therapy, that can overdosing can lead to a similar picture of high normal T3 or high normal T3 T4 with a suppressed TSH. Next slide, please. Okay, so first thing to ask in such a scenario is whether patient is taking levothyroxine therapy. If not, you suspect an endogenous cause. TSH is between 0.1 to 4.5. This is not a cause for major concern. Repeat measurement in 2 to 12 weeks. If the repeat TSH is again in the borderline range, you don't need to treat generally. You can keep under close follow-up. However, if TSH is less than 0.1, you repeat measurement, and if repeat measurement is again showing a suppression of less than 0.1, you treat, especially in risk factors. So elderly individuals, you would like to treat even persistent subclinical hyperthyroidism. Next slide. The eighth scenario is about 18-week pregnant women, and she's referred from gynecology for high thyroid hormone levels because they have done thyroid function tests as part of routine screening. Her history and examination totally normal, and what do we see? A mildly elevated T3 with elevated T4 and normal TSH. So is it high T3, high T4 with normal TSH? So is it a secondary hyperthyroidism originating from the pituitary gland, or there are other differentials that we should entertain? But here, important to understand that during pregnancy, because of estrogen rise, you expect increase in thyroxine binding globulin, and because of increase in thyroxine binding globulin, T3 and T4 total levels will increase. In fact, it is said that during pregnancy, after 7 weeks, there is 5% increase in total T4 per week. So such that by 16 weeks, it is 1.5 times the upper limit of normal. So it is very simple out here. So my lab reference range is 14.1. That is the upper limit of normal for my lab. So at 16 weeks of pregnancy, I will expect that my upper limit of normal will be 21 micrograms per DL. So anything that is coming within 21 micrograms per DL for this pregnant patient is considered to be normal. We don't generally rely on free hormone assays during pregnancies, because free hormone assays during pregnancy are also unreliable because changes in lots of binding globulin equilibrium occurs. So we rely on total thyroid hormone measurements even during pregnancy. And even in patients with Graves' disease who are treated during pregnancy, we try and maintain T4 levels in upper limit of normal. We use the revised reference range, that is 50% increase at 16 weeks. So after 16 weeks, my upper limit of normal automatically changes to 21 micrograms per DL. Next slide. Now, moving on to the next scenario, a 37-year-old female who is a known case of autoimmune primary hypothyroidism. She's using levothyroxine 100 micrograms per day. Now, when we see her thyroid function test, what do we see? Her T4 is high, free T4 is also high, and TSH is also high. So she's on levothyroxine, but she's presenting a atypical or funny kind of thyroid function test. T4 and free T4 are high and TSH is also high. And in such an instance, it is important to ask whether there is erratic compliance, because when patients tend to take levothyroxine just uh, before the thyroid function test, say 3 to 4 days before their test is planned, and they take multiple tablets together, they can end up with high thyroid hormone levels and still high TSH. And this is something that we have to always ask, whether there is exogenous levothyroxine therapy with erratic compliance. Next slide. So last two cases we have seen high T4 and high T3 with normal or elevated TSH, and this is the most difficult thyroid function test that we can encounter. Amongst these, I have discussed the two simpler ones. One is thyroid binding globulin excess. So anytime you are seeing high T3 and high T4 with normal TSH, first job to do is to rule out a TBG excess, and that can be done through good history taking, whether patient is pregnant, whether the patient is taking estrogen, oral contraceptive pills. Do a free hormone, that will clinch the diagnosis. Other differentials, they are actually a bit difficult, and I'm not going to discuss how do we tease out the differential diagnosis. For example, resistance to thyroid hormone, TSHoma, familial dysalbuminic hyperthyroxemia, and acute non-thyroidal illness. Next slide, please. Other differentials could include, transporter mutations such as MCT8, then mutations in the genes that lead to impairment of deiodinase functions, autoantibodies, assay interferences, and finally levothyroxine therapy. So when there is a setting of use of levothyroxine therapy with intermittent or erratic compliance, you can always get a funny type of thyroid function test. So always advise the patient that the test should be drawn before the morning dose of levothyroxine, especially if you are measuring T4 alongside TSH. Next slide. So now I'll discuss some brief aspects about hypothyroidism management. Next slide, please. So we have already discussed that etiology of hypothyroidism could be primary, which is originating within the thyroid gland, and this could be acquired, of which Hashimoto thyroiditis or autoimmune hypothyroidism is the most common. Other causes would include iodine deficiency, which has become less common these days. Drugs, many of the drugs which are used in clinical practice, including interferons, including cancer chemotherapy drugs such as immune checkpoint inhibitors. These are certain drugs that can lead to hypothyroidism. Post surgery, post thyroidectomy, you can get hypothyroidism. Post radioiodine ablation for Graves' disease, you can get hypothyroidism. Congenital hypothyroidism is something that Ashima madam will discuss. Transient post thyroiditis hypothyroidism, and consumptive hypothyroidism, which is due to presence of hemangiomas that upregulate type 3 deiodinase that tend to deactivate thyroid hormone. And then you have secondary hypothyroidism, which can again be acquired, which could be due to a tumor such as a pituitary adenoma, craniopharyngioma, germinoma, so on and so forth, or due to congenital, such as due to a transcription factor defect. Next slide. So primary hypothyroidism roughly comprises more than 95%, or we can say about 99% of all cases of hypothyroidism. Once a day levothyroxine remains the standard of care for treatment of hypothyroidism. And the standard replacement dose in somebody who is athyroidic, that means a complete thyroid gland has been removed, or there is complete deficiency of thyroid hormone, is between 1.6 to 1.8 micrograms per kg per day. The levothyroxine is used for treatment because it has a long half-life of 7 days. So it doesn't matter, even if you miss the tablet for one day, you can ask the patient to take a dose correction on the next day. You can ask the patient to take 2 tablets on the second day. In fact, for some non-compliant patient, we do advise once a week levothyroxine therapy when there is compliance is a major issue. So because of the long half-life of levothyroxine, it can be given in once a day dosing. It has got good intestinal absorption. The absorption is somewhere around 70 to 80%. It is efficacious. Side effect profile is favorable. It is acceptable, and it is available at low cost. It is absorbed in jejunum and ileum. Absorption occurs within 3 to 4 hours of ingestion, and it requires adequate gastric acidity for dissolution. And that's why a good amount of acidic pH is required for digestion of levothyroxine tablets. Otherwise, if you have a non-acidic pH, then thyroxine absorption will be impaired. Next slide. And this is something that is very important. Bioequivalence, which is claimed by different brands, does not equate to clinical equivalence. So if you are changing from one brand of levothyroxine to another brand, or you're changing from one brand to a generic preparation, you may see fluctuations in TSH levels. So it is an ideal advisory to maintain the patient on same brand of levothyroxine, or if there is a change in formulation, then you should retest TSH within 6 weeks after the change, even if patient has had a stable thyroxine dosing and stable TSH levels prior to the change. So we carefully check the prescribed and dispensed dose. It is very common to see we have seen patients taking advised levothyroxine 125 micrograms. Patient comes with a TSH of more than 100 on follow-up, and when we check the dispensed tablet, it is actually 12.5 micrograms which is being dispensed. So whenever you are encountering a patient with elevated TSH, despite you feel that there is an adequate levothyroxine that's been prescribed, carefully check the dispensed dose also. The tablet should be taken empty stomach 60 minutes before meals or beverages, because this can also impair thyroxine absorption. For pregnant patients, you should have at least 4 hours gap between thyroxine and calcium or iron tablets. Use of proton pump inhibitor should be avoided where possible. Where it is not possible, it should be spaced out at least 12 hours gap. Do not change formulation. And for storage, you should avoid excessive heat and moisture. Next slide, please. Target of treatment for primary hypothyroidism. For secondary, I've already discussed it is free T4. For primary, it is TSH, which is measured 6 to 8 weeks after dose initiation. Levothyroxine has a half-life of 7 days, so it takes about 6 to 8 weeks for it to reach the correct levels and to normalize TSH. And this is the stage at which steady levels of thyroid hormone are reached and neither level of TSH is achieved. Target TSH in normal range, but this also needs to be individualized. As I have discussed, for an elderly person, your TSH target may relax. For a pregnant patient, you may want to have a more stringent target. So oral levothyroxine is a standard of treatment. Standard advisory should be provided for best results, which include adequate fasting, adequate gap with other medications, not to use PPIs, and different formulations may not be clinically equivalent. TSH is the main target of our treatment. Now, an important troubleshooting in clinical practice is that patient is taking levothyroxine, but there is issue in controlling TSH. TSH is still harboring around 10, 20, or TSH is fluctuating, and the etiologies for this could be, one is poor adherence, which is the most common cause for treatment-resistant hypothyroidism. Then there could be issues with the potency of the tablet, because the tablet has been stored in an incorrect environment. It's been stored in a humid environment, or it's been stored in a hot environment, or that there is differences in prescribed and dispensed strength, as I have discussed, or there has been change in formulation, or there's been interference with food and drugs. Patient is not taking adequate gap with tea, coffee, or patient is taking products such as soy products that can interfere with thyroxine absorption, or tablets of calcium, iron, PPIs that can interfere with thyroxine absorption. Next. So there are several drugs and food that can interfere with thyroxine, and this is something when patient presents to us, we have to closely ask for the interfering drugs and food history in our clinical practice. Next. Then there could be GI issues. So there could be GI issues, which means maldigestion related to hypochlorite. As I've discussed, acidic pH is essential for thyroxine absorption. So proton pump inhibitor therapy, H. pylori infection, autoimmune atrophic gastritis, they could cause a levothyroxine maldigestion. Then there could be intestinal malabsorption, which could be related to celiac disease. So if a patient has type 1 diabetes, patient is prone to other autoimmune diseases, including autoimmune hypothyroidism, and patient can also develop celiac disease, lactose intolerance, short bowel syndrome as a result of bariatric surgery, inflammatory bowel disease, and infiltrative enteropathy. Mind you, some of these diseases may be occult. That means that they may not present with GI manifestation, and treatment-resistant hypothyroidism may be the overt or monosymptomatic presentation. So it is not that the patient is not having any GI issues. We do not suspect celiac disease. If you prove that patient is having treatment-resistant hypothyroidism and you see subtle clues, you should still rule out celiac disease even in such scenarios. Next slide. So this is what I meant to say, that some diseases such as lactose malabsorption, celiac disease can be frequently occult, while some diseases like short bowel syndrome, biliopancreatic diversion as a result of bariatric surgery are more likely to be clinical evident, and so we need to have a close index of suspicion in most cases. Next. Other could be increased levothyroxine requirement because you are using certain drugs that increase metabolism of levothyroxine. Somebody is on antithyroid drug, is on antitubercular drug, is using rifampicin, so levothyroxine requirement will increase. Somebody is on carbamazepine, phenytoin, requirements are going to increase. Tyrosine kinase inhibitors, they also increase requirement for levothyroxine. If there is a significant weight gain during pregnancy, thyroxine requirement increase by 30 to 50%, and it is a good clinical practice to increase the dose of levothyroxine at the first visit itself. So what we do is we increase the dose by 25 to 30%, and whatever pre-pregnancy dose patient is taking, a good clinical practice may be to make it 9/7. So if patient is taking 50 micrograms daily, you can make it 50 micrograms daily, but 100 micrograms on the weekend. So that becomes 2 tablets on the sixth and seventh day. So it becomes 9 tablets over 7 days. Now, there could be certain miscellaneous causes for poor TSH control. These could be nephrotic syndrome, thyroid hormone resistance, consumptive hypothyroidism, heterophile antibodies, macro-TSH, which are lab assay interference, and these need a closer look. And such cases should probably be referred to a clinical endocrinologist. Now, moving on to hyperthyroidism. So, etiologies of thyrotoxicosis and hyperthyroidism are slightly different terms. Thyrotoxicosis refers to a hypermetabolic state related to increased T3 and T4. Now, this could be related to increased production of gland related hormones, or it could be due to release of hormones from a dying or a destructed gland. While hyperthyroidism means a hyper-functioning thyroid gland. So, etiologies will include Graves' disease, toxic multinodular goiter, solitary toxic adenoma, iodine-induced hyperthyroidism, gestational thyrotoxicosis, trophoblastic disease such as H. molar pregnancy, and you have secondary hyperthyroidism related to TSH secreting adenoma. Next slide. Other etiologies which causes thyrotoxicosis but not associated with hyperthyroidism, these include subacute thyroiditis, postpartum thyroiditis, drug-induced thyroiditis, thyrotoxicosis factitia, where you are taking lots of thyroxine exogenously, and ectopic thyroid tissue. So these are the conditions where you have thyrotoxicosis, but there is no hyper-functioning thyroid gland in the thyroid bed region. Next slide. Management we have already discussed. For subacute thyroiditis, it is the two most common differentials are subacute thyroiditis versus Graves' disease. And for subacute thyroiditis, beta blockers for symptomatic relief, you can use NSAIDs such as naproxen or indomethacin in case of pain and tenderness. If it does not resolve even with that, you can use a short course of steroids for say 2 to 3 weeks. For gestational thyrotoxicosis, again, supportive treatment. Very, very rarely you require low dose antithyroid drugs in very severe cases. The next slide. For autonomous functioning thyroid nodule, because there is a single foci of increased thyroid activity with surrounding gland being suppressed, you can very well use antithyroid drugs to initially achieve euthyroid state, followed by iodine 131 radioiodine ablation. For toxic multinodular goiters, generally we prefer to use antithyroid drugs, achieve euthyroid state, and followed by surgery, although radioiodine ablation can also be used in these cases. Next slide. Graves' disease, which is an autoimmune form of hyperthyroidism, which is TSH receptor antibody mediated hyperthyroidism. You can go for two different kinds of strategies. The more and more literature is now favoring use of antithyroid drugs or medical management for Graves' disease. So you start with antithyroid drugs, give them for a period of 12 to 18 months, where you expect remission of disease in about 50% cases. Those cases which do not undergo remission, they can be sent for definitive therapy, which could include iodine ablation or surgery, or they can be given another course of antithyroid drugs for another 12 to 18 months, and then you recheck their TSH receptor antibody levels. In the ablative therapy, you have radioiodine and thyroidectomy. The issues are that with radioiodine and thyroidectomy, you have lifelong hypothyroidism, so you convert one disease into another disease. While with antithyroid drugs, there is no risk for hypothyroidism. You can maintain euthyroidism at least in a certain subset of patients. Next slide. In terms of antithyroid drugs, we use thionomides, which include carbimazole, methimazole, and propylthiouracil. Propylthiouracil in contemporary clinical practice has limited role. It is only used in cases of thyroid storm because it inhibits it inhibits T4 to T3 conversion, so it is believed to improve thyroid storm better. And second, it is only used in first trimester of pregnancy because the teratogenic effects of propyl thyroxine in first trimester of pregnancy are lesser. Otherwise, we tend to use carbimazole and methimazole, the equivalent doses being 10 milligrams of carbimazole equivalents to 6 milligrams of methimazole and 100 milligrams of propyl thyroxine. Important side effects, but which are very rare, include agranulocytosis with uh, thionomides. And agranulocytosis is defined as absolute neutrophil count of less than 500. Any person develops agranulocytosis any time, you have to stop antithyroid drugs, and you have to get a you have to wait for the resolution of the abnormality, and then only you can restart, or you have to look for other modalities of treatment, which could include lithium, steroids, stabilize, and then you can go for radiation ablation or surgery. Other options include radiation ablation and surgery, which are used on case-to-case basis on a definitive therapy. For patients who require definitive therapy, generally we don't use radiation ablation and surgery as upfront therapies, but different centers may have different approaches. So with this, I will come to an end of my presentation, and thank you so much for your kind attention.
Thank you so much, sir. That was a wonderful presentation. We'll take up the questions. Sir, are you comfortable taking up questions now, or shall we take up at the last of this session?
Any which way, I am comfortable both ways.
Let's first continue with this session.
Okay, ma'am. Okay, ma'am. Okay. Moving forward, I would like to invite our second guest speaker, Dr. Ashima Dabas, ma'am, Professor Pediatrics, MAMC and Ellen Hospital, New Delhi. Dr. Ashima Dabas is a professor of pediatrics in Maulana Azad Medical College and Associated Loknayak Hospital, New Delhi. She was a clinical fellow in European Society of Pediatric Endocrinology, Manchester, UK, at the time of 2022 to 2023. And she's an associate editor, Indian Pediatrics Official Journal of IAP. She has received several awards, such as one international Maria Luisa Bianchi Award 2022, award for 5 best papers, gold medal 5, including best student MBBS and MD pediatrics. Her research interests are pediatric endocrinology, growth, bone disorders, and she has 75 journal publication and has written 12 chapters and authored 1 book. Today, she is going to take up the session on early detection of thyroid disorders in children. Over to you, ma'am.
Thank you. Thank you. So I'll just share my screen. I hope. So this is visible.
Yes, ma'am, it's visible.
And it is slideshow mode, and I can start if it is okay.
Yes, ma'am.
So at the outset, thank you NHSRC and Sangeeta ma'am for giving this opportunity for a topic which is very close to my heart and work. So my talk has been made simpler because Dr. Alpesh has very nicely covered the common pitfalls that will remain common for both pediatric and adult practice. And with that background, I would like to focus my talk mainly. Yes, I will be talking on congenital hypothyroidism, but also how acquired hypothyroidism differs in presentation and management in children. Dr. Alpesh has already covered hyperthyroidism in much detail, but I will just briefly mention how presentation in children is difficult and management in terms of clinical presentations may be challenging. Thyroid function test more or less would remain the same in terms of interpretation and ordering. But yes, lastly, we'll see a few disorders. So before we go on to cases or understanding presentations, a word about how the thyroid gland develops, because this may not be very applicable when we are understanding acquired disorders, but we will be definitely interested in knowing this when we see children who present early with symptoms. So just to recapitulate, there's a foramen cecum which develops in the first uh, first few days of life. From this, there grows an outpouch which is like the thyroglossal cyst, thyroglossal duct. This duct would then migrate down to reach the position in the neck where a bilobed structure of which is the so-called thyroid gland would form, and with time this duct has to disappear as embryogenesis proceeds. Within this thyroid gland, most of these would be forming the thyroid would be lined by the columnar epithelium and the pubertal epithelium and would have the colloid in to form the structure of the thyroid gland, but this would also be joined with the ultimobranchial bodies from the other pharyngeal arches, which will ultimately form the C cells. The function of the C cells may not be very important when we are understanding thyroid physiology, but becomes important when we are looking at other issues of thyroid, especially when they are about to be operated. Before we go on to understanding function, uh, we need not understand all the genes and the transporters involved here, but just remember there is iodine, enough iodine in the blood, which has to be taken up by the sodium iodine symporter. And with this, an oxidation would occur, which will eventually form the T4 and the T3 hormone. So, understanding this is important because Dr. Alpesh also mentioned a lot of conditions where there is sickness, where there is inotropes, etc., where this balance and this uptake, etc., will get compromised. All these will cause errors in labs, which gets interpreted as thyroid disorders, and that is why an understanding of basic physiology is important. It is ultimately the stored formed hormone which has to be released in the blood and which we are measuring, right? So this is just a recapitulation. So this was already covered of how the balance is being maintained in the body, and I will also focus on the same aspects. The only thing that I'm going to touch additional would be the first bracket, that is the age at presentation, or how is it going to determine whether thyroid presenting in childhood age would be congenital or acquired hypothyroidism. The rest of the principles would remain the same. Okay, so we see the first case. I think Dr. Alpesh also started with the case of thyroid. So this is an 11-year-old girl who's presented with swelling in the anterior part of the neck for almost 2 months. So it's been a slow growing anterior midline swelling. There is no history of any lethargy or constipation. In children, the first thing that I would emphasize, and the reason why it has been put up on the slide, is please identify growth faltering or growth disturbance in all children who are presenting with these non-specific, non-infectious complaints. So over here, as we see, the weight and the height, both of them were little on the lower side, but not very significantly affected. If in the audience you would want an understanding of how we interpret these as per different age, we can do that in the end when we have time. We also we also are in the habit of also checking the pubertal progression in all children who are peripubertal age group. So any girl who is above 8 9 years of age and similar age in boys, we would be interested in checking whether they are progressing as per their pubertal milestones or not, because this again gives us a lot of clue of underlying pathology. So, on examination, as we see, if you remember palpation of thyroid gland, where the fingers have to come from backside of the neck, and the palpation has to be done such that the fingers roll over the anterior surface of the neck. So we do find that this is the thyroid gland, which is non-tender. It is not tender, and it is little firm. So after having understood what to order, all of you can just maybe keep a note of whatever as the questions would be coming up. We don't have time for involving an interactive chat option here, but I will just request you to keep the questions or the answers coming in your mind. And if they differ, we can again discuss in the end. So what would we want to order? So yes, as was very rightly mentioned, the first test that we would want to do with this goiter is a TSH. But here, because this is an overt thyroid pathology that we are suspecting, so we would also be interested in measuring the hormones and not just a screening TSH. But as was discussed, probably a single T4 alone would be better than doing a T3 measurement. So just to reiterate, there are very very limited indications of ordering T3 in, and more so in childhood, where the etiology, if suspected to be a hyperthyroid state, we would be doing that. Or if there is, as Dr. Alpesh had shown, a case of hashitoxicosis versus Graves, we would be interested in doing that. There was a mention of what happens when there is a 60-year-old, or I think an 80-year-old geriatric person who comes with a mildly elevated TSH. So yes, whenever we are interpreting TSH, we have to keep all these variations in mind, and a word about how it may also change with puberty, where the variation could be different. So we can skip the interpretation of the thyroid function test that has been very beautifully covered by Dr. Alpesh. So I will not probably spend more time on this, but just a reminder for all of you are ordering thyroid function test. Instead of writing thyroid function test, it is a nice practice to write down TSH and maybe a free T4 or a total T4. In children, sometimes yes, especially in younger children, we would be it'll be wiser to measure FT4, provided you know that your lab is not going to create an error, and the QC, the quality controls, etc., are done better. Otherwise, a total T4 would serve the same purpose as a free T4 in childhood, because there aren't many variations that you're expecting as in a pregnant state. So whenever you get a report of the thyroid function test, please do read what assay or what method of assessment was used by the lab. These days, most of the labs have now shifted to electrochemiluminescence or fluorescent immunoassays, and they are not doing radioimmunoassay or immunometric assays. But if you do get a report which has used a very rudimentary assay, then the margin of error in that report is going to be high. This grid also I will skip. So we now come to the measurement of antibodies. So unlike adults where antibodies people usually get ordered, please remember that even in children there could be a proportion of children who can test positive for an antibody. Only the mere presence of a positive antibody does not mean that the child has hypothyroidism or has a disease. It's just that it's an antibody which is positive. So in one of the examples where Dr. Alpesh had shown that the patient had a borderline TSH and an antibody which was 300 times, we would also be worried about an excessively high antibody level. But we will look at the case and we will discuss when are we ordering that. So the TRAB antibodies have already been mentioned. They don't have much role in hypothyroidism, but yes, they will be useful when we are investigating a child with hyperthyroidism, and they are very specific for Graves' disease. Sometimes lab as part of panels also offer an anti-thyroglobulin antibodies. Again, in the absence of if there is an indication to be measuring an antibody, a TPO level would suffice. So there isn't any need to order many fancy antibodies because it isn't going to change your diagnosis or management in any form. So please reserve the patient's money instead of ordering all these hi-fi tests. There are something which are very simple things to order. Because my child presented with goiter, many times there are reports of ultrasound, and for all we know that even FNAs have been done outside, and then children get referred with no added advantage. So that is why I've included a mention of recommendations where we need an ultrasound. So yes, if on palpation you feel that there is a thyroid nodule or the surface is not uniform, you would want to get an ultrasound done, or if there is asymmetry, or if there is any associated cervical lymphadenopathy, or if there are patients who are cancer survivors and have now come with a thyroid swelling. So as you can see, these indications are rarer in pediatric population. So please don't jump directly to ordering hi-fi scans and hi-fi antibodies. This is how a gland would look like in the most common condition, which we all know as Hashimoto's thyroiditis. So whenever there is an outside report of ultrasound, please make a habit to read what they have reported in terms of findings instead of just the conclusion. So as you can see, they are different cystic lesions in the ultrasound. So this is the neck, this is the thyroid lobe that you can see. There are small cystic micronodular structures, and on Doppler there would be decreased flow. So it is not a very vascular because this is all infiltrative disorder, infiltrative thyroid involvement. So we come back to our case, as she had a goiter and she was just 11 years. Otherwise, growth was not much, has not started to default much. So she did have an elevated TSH and the FT4 was low. And because she also came with an ultrasound, so yes, it had an heterogeneous echo texture, but no sinister findings. So we started her on levothyroxine. So now, unlike adults where the practice is to start more with a uniform dose, we would want to titrate it to a dose which adjusts to the body surface or the per kg body weight in children. Usually the range is 3 to 5 microgram per kg per day in children. But please remember, if it is the closer you can round it off to a tablet which is available, like a 25 or a 50 microgram tablet, it is easier. 3 does not mean that it has to be 3. Sometimes even a dose of 2.5 or 2.25 microgram per kg per day is okay. So as Dr. Alpesh said, daily has to be taken first thing in the morning. So for children who are not like adults but they are children, something that works with my kids is when I tell them, because you don't forget to brush your teeth every day, just before brushing, a little before, you have to remember taking your medication, right? And compliance has to be ensured. Sometimes when the hypothyroidism has been persisting for quite some time, at that time starting the entire dose of 3 or 3.5 microgram can sometimes precipitate cardiovascular instability. So sometimes it is a good idea to start half the dose and then gradually build up the dose over the next 1 to 2 weeks, right? And in this case, even though I had not ordered the anti-TPO, she already had an anti-TPO from outside, which was raised. So this is just to illustrate that getting an antibody, yes or no, does not make much of a difference for me in managing this child, right? So the learning points, remember, goiter can be euthyroid, hypothyroid, or hyperthyroid. So yes, for every goiter, a thyroid function has to be done. Clinical examination on ultrasound neck is recommended, but not short of a good clinical examination. There is no role of routine fine needle aspirations for all goiters. Please do not expose children to invasive investigations. And very important, after starting therapy, you are not just going to monitor the response in terms of a normalization of a thyroid function test, but also have to monitor growth and whether the symptoms have abated or not. And towards the end, I'll show you how we have missed cases. Right. So just for the audience to note down, what would you have done if she was euthyroid with goiter? How many of you would have monitored? How many of you would have repeated a thyroid function test? How many of you would have tempted to start thyroxine because she's in the pivotal age group? So just make a note of that. If we have time, we'll come back and discuss. So this is a second 8-year-old girl who actually walks in with a thyroid which they feel is abnormal. She is a very picky eater. There are no other features of hypo or hypothyroidism. There is no goiter. So when I say no features, she has no growth faltering, no developmental issues, no skin changes, nothing. And there is no family history of thyroid. And this is the TSH that she has, which are normal FT4 and FT3. So again, please make a note for in both the presentations you saw, be very careful when you're writing an FT4 report, because this has to be with the unit and with the range. These will differ lab to lab, as you can see between mine and Dr. Alpesh's slide. So as we can see, this is the classical condition where we have a normal FT4, but the TSH is less than 10, but definitely not in the normal range. So as was wisely summed up for an approach in adults, similarly in childhood, we would be wanting to do a repeat TSH first on waiting, as per the risk factors which Dr. Alpesh had mentioned, in addition to presence of goiter, female gender, and a highly elevated TPO antibody, other autoimmune signs and other syndromic signs. Sometimes children with Down syndrome, Turner syndrome might have just this mildly elevated TSH, and you would want to screen them for any other associated systemic disease. So we have children with celiac disease who present with initially with just the child not thriving well, they don't eat great, and they may just be detected initially on this abnormal thyroid level. A word also I wanted to mention, please remember these borderline TSH abnormalities cannot cause systemic features of thyroid disorders like short stature, developmental delays. If you have this borderline TSH and you have a sign or symptom which is very much fitting with a problem which could be hypothyroid, this is actually a association and the child might actually be having an underlying syndromic disorder. So please keep a note of all these things. And in this child, we would be interested in repeating this on follow up to see what is the etiology of the same. And this is one of the large cohorts that had evaluated as to what happens to children who were detected to be subclinical hypothyroidism on the initial testing. So as you can see, amongst all those who had a TSH between 5.5 to within 10, most of them, the majority, tested out to be normal on serial follow-up. So in most of these children, we are just going to do a close observation, provided we have ruled out any other systemic abnormality or association. We now come to the third child, who is a 7-year, 9-month-old child who's presenting with dyspnea, sleep disturbances, and fever and cough for 7 days. So, if you see, these symptoms are nowhere close to something which you read as thyroid disorders or clinical signs and symptoms of low or high thyroid. But yes, this is what the child presented with. On close examination, because probably we are tuned to seeing it, if you can make out, there was a very, very soft, small goiter which was visible in this child. On examination, this child, when he presented with difficulty in breathing, we were interested in ruling out a respiratory or a cardiac cause, and we found that this child also had features of congestive heart failure. He had a very high heart rate. His JVP was raised. The neck veins were all engorged. He had hepatomegaly. And yes, a very good meticulous examination. While we were looking for JVP, we realized that this child also has a small soft goiter. On systemic examination, he has an ejection systolic murmur at the pulmonary area. So, for most of you who are trying to find, who are almost there at the diagnosis, this child, the next thing that you would be looking for in this child, in a child who's presenting with hemodynamic instability with a goiter, I'm worried about a hyperdynamic state, and I'm looking at the most common differential, which has to be a Graves' disease. So this child did not also had eye signs. Um, for the sake of making retaining anonymity, probably that picture never captured those eye signs. But what I'm showing you in the second picture is not of this child, but of another child. anybody who can make out subtle dysmorphisms in this case. So this child, so she definitely has orbital signs of Graves' disease, where you can see that there is clear cut proptosis, the lid aperture is increased, but she also has features of syndrome. She is a case of Down syndrome who presented with similar features. So she was never very hyperactive. She was just a simple child with Down syndrome who was following up. And suddenly, one after a few months, the mother came in where she said that she has become very agitated. Her behavioral issues have increased. She doesn't listen to them anymore. There is difficulty in complying with her developmental and settings with the psychologist. And there, because of these eye signs, she didn't have any goiter. But because of this, we were very quick to order a repeat thyroid function, and we realized that even she has gone into a state of hyperthyroidism. So coming back to our index case, because we were suspecting hyperthyroidism, this is how the labs came out in by the next day. So he had a suppressed TSH, FT4 and FT3 were again very raised. So yes, there is a role of measuring the FT3 by FT4 ratio in Graves' disease, which can also differentiate as Hashitoxicosis. TP or antibodies were done just as part of routine. They are not very confirmatory, but they can still be positive in any autoimmune condition. And yes, in this child, the TRAB antibodies were strongly positive. Because he had a goiter, an ultrasound was also done. And as we can see in Graves' disease, it would be a similar picture where there is an increased gland, but then the vascularity is very high. Similar to the approach in adults, we also ordered a thyroid scan, and as can be seen that this thyroid gland is bulky, increased, and is showing an increased scan. So the diagnosis was of Graves' disease, and we started this child on carbimazole. So carbimazole or methimazole both can be chosen, and both are given as oral tablets initially in divided doses, and then the child can be shifted to a maintenance therapy. So for now, at least identifying, referring, and maybe starting stabilizing the cardiac condition, and then following up or referring the child for further care is all that is required from a center. So this is just how the ultrasound would differ in Graves' disease. I can skip that for the interest of time. We now, so after having looked at acquired disorders where presentations may be a little different, but management principles and diagnosis, etc., would remain the same, whether it is an older child, adult, or an elderly. We now come to the next part, which is where we are talking of a congenital hypothyroidism. So remember the picture that we had shown you initially, where we are looking at the thyroid gland which is developing after descending from the foramen cecum with the help of a thyroglossal cyst. So, any problem in this development or this descent can cause an abnormality in the thyroid function later. So, it is important that we are able to identify this, because this is a treatable disorder. So, if it is diagnosed and picked up early, what we can prevent is a lifelong stigma of being developmentally retarded and not growing well. So there can be problems in the development where the gland may not form or may form abnormally, which is dysgenesis or agenesis, or it may the descent may be abnormal and it may get blocked or arrested at some point, whereas the thyroid may actually not be found in the neck position but maybe somewhere in the ectopic position. And if we remember the function, the cycle of thyroid hormone synthesis, there could be a defect in any of the genes. So right from iodine uptake to where it binds with thyroglobulin, where it gets oxidized, where it couples, etc. Any of these defects can lead to a defective or a low hormone production, which can also cause hypothyroidism. So just to illustrate, so this is a 6-year-old girl who was brought to us with short stature. Now the strange thing is, if you look at her, she doesn't look more than 2.5, 3 years old. But yes, this was the apathy when she walked in. She was 6 years old already. She luckily got diagnosed with hypothyroidism at 1.5 years of age. At that time, also the concerns were that the child had not started to sit, had not started to stand, had was difficulty. She had a lot of difficulty in feeding in the initial 1 year of life, and was obviously not thriving well. So somebody very intelligently had ordered a thyroid function test in view of her poor growth and developmental delays initially. She was diagnosed as hypothyroidism and was started on thyroxine. She continued till she discontinued. So personal reasons here were COVID actually, where they just discontinued her treatment. And if you look at her weight and height, she is just 14 kgs and her height is just 94 centimeters. So apparently just between how a 3 or a 3.5 year old child would look like. So what are we looking at? So for people who are actually very happy that somebody picked up at her at 1.5 years age should feel equally miserable as much as the family who missed the doses for another 2 years. Why? The brain growth occurs maximum in the first 2 years of life. So if we are able to detect and treat hypothyroidism in these 2 years of life, what we are going to ensure every child with congenital hypothyroidism is going to be an equivalent normal quality of life, because any delay in starting levothyroxine therapy is going to add to a loss of IQ by almost 5 to 6 months. So imagine even a 3 month or a 4 month or a 6 month delay, the IQ is already lost by almost 25 to 30, right? And this one, when she came at 1.5 years of age, if you can look at the open mouth, loss of ptosis, etc., she already had very clear cut, starking features of cretinism as we would have read. So, the reason why I have not put up any clinical features of congenital hypothyroidism is to re emphasize there aren't any clinical features of congenital hypothyroidism that we want anybody to remember now, because we want to move on to a to a space where congenital hypothyroidism can get detected and get treated timely, right? So we are looking at a concept where we want to emphasize the role of newborn screening. So newborn screening is a tool where you are wanting to screen one who is abnormal of those who look totally abnormal, who look totally normal or same. So you need this something which is like a lens which can quickly scan through to differentiate who is clearly normal versus clearly abnormal. So if you remember the physiology of thyroid hormone function, a baby who has congenital hypothyroidism will be born and will look totally normal because they are protected by the placental transfer of uh, thyroid hormones, and also because the thyroid gland would function in some capacity when they are even in the fetus. So they are not born abnormal. They don't look cretin when they are born immediately. But yes, as soon as within the first few months of life, they may start showing features in terms of difficulty in feeding, jaundice which is persisting, right? And those coarse facies, heart failures, etc., are late signs to develop. We've already missed the bus if the child develops that. So we want to detect them before they become symptomatic for any thyroid disorder. So what do we do? So as we are, so our favorite molecule is TSH. It is easy, it is dependable, it is readily available. So we would be wanting to measure the TSH, and if the TSH is high, we know that this child is likely not producing enough hormones. We could have also measured the T4 levels in children, but please remember when we are doing it universal. So universal means for every child who's born, if we were to check one, then I would put all my money on TSH, because measuring TSH is simpler. Labs would do it more cost effective. The only window that we have to remember is, if you look at this graph closely, TSH when the baby is just born may not show elevated, but the first 24 to say 36 hours there is a TSH surge which occurs in the body. So over here, if I'm sampling a normal child at 12 hours of life, even then the TSH is going to be high. So this may be a normal physiology and not a primary hypothyroidism in this child. So that is why the window is actually just at birth, which is cord blood, where it is easiest and simplest. What Whenever the cord is being clamped in the delivery room, we just need to take out 2 ml of sample from the placental end. Does not need any pricking. The baby does not get any investigation done in terms of prick, and this sample as such can be just sent to the lab to measure the TSH. The report can be available in within 2 to 4 hours, right? So we interpret based on the cord blood TSH. And for all of you who want those cutoffs as to what do we do with these guidelines, these are all available in standard treatment guidelines as part of workflow. So you can just refer, but just remember, if TSH has been taken at the right time would mean either cord blood, which is at birth, or after 36 to 48 hours, which is this, where the the surge would stabilize. At any of these two time points, if the TSH has been taken off, and if it is more than 20, then I have to be little wary of following up this child closely. Any TSH which is less than 20 on the first screen is normal. And if the period has been between 24 to 48 hours, a cutoff of less than 34, I'm normal, but between 22 to till beyond 34, I would be worried. So if it is more than 80, because definitely this is not something which is normal, I would want to start treatment immediately and yet take out a confirmatory venous sample. In both the other cases, treatment can be started provided you have taken a venous confirmatory sample. The reason why we are talking of confirmatory sample, because remember, there are a lot of errors which can happen when samples are being done from cord or from after 48 hours of life. Sample mixing up, processing problems, lab ID problems. There many problems can be there. So for significantly elevated TSH, please do not wait. Start the hormones, start thyroxine replacement, and send the venous confirmatory sample. So this is where we were talking of cord blood, which is very simple to do. The other revolutionary change that has been brought about is the use of filter paper based dried blood spots. As you can see in the picture, this is a small filter paper, the one which we use to do chemistry experiments, something similar to that, but definitely this is a medical grade filter paper where the infant is sampled. So if this is the soul of the infant, we would be sampling from the sides of the infant using a small lancet, and those drops of bloods are collected on this filter paper. This filter paper gets exposed to a machine where there is a little puncher. If you can make this out, it would punch and take out these little holes of blood, and these would get eluted to measure the analyte in the blood that we are interested in. So most of the corporate structure has moved on to DBS based screening. The advantage of this is that you could measure more than just TSH in these dried blood spots. This is something like a blood bank repository where the blood sample gets saved, and these can be shipped and transported for other analysis also if needed, right? But the problem is scalability, cost, effectiveness, etc. is a big challenge. So in places where DBS is still not available and cannot be afforded, this can be done if complementary, but cord blood is something which can be easily done at all centers. So we would strongly advocate for a mandatory universal newborn screening for thyroid disorders, and at least do a cord blood. So once you've done the cord blood or the DBS and the levels shows an increase, you would want to start thyroxine the same way. Here, I think I have a slide towards the later part. The treatment of choice remains thyroxine, but the dose is higher. So the dose higher would mean a dose of 10 to 15 microgram per kg. So dose is almost 3 times to what you would treat with an adult or an older child with acquired hypothyroidism. And remember, these are babies. We still don't have any liquid formulation of levothyroxine. So the tablet has to be crushed in a spoon and has to be given with breast milk. That is all we advise the mothers to do as the first thing in the morning. So they can't have fasting and etc. etc. But the first thing when the baby gets up in the morning, the tablet has to be crushed, given in the spoon with the breast milk daily as per compliance, right? The next thing that we would be interested in checking in a child who has an abnormal screen at birth is whether this problem is because of a structural problem or a functional problem. So ultrasound and technetium scan both can be ordered, and these are from the Indian Academy of Pediatrics endorsed guidelines, the ISPE guidelines of doing a thyroid scan. So thyroid scans these days are available in most centers. They are not very costly, but just a caution, please remember to refer this child for an ultrasound and a scan. And as can be done, the only line that I would want you to remember is imaging cannot be an excuse of not starting treatment. If there is an abnormal screen based on TSH alone, please start treatment and refer. Okay. You can do a confirmatory sample which will involve a TSH and a T4 measurement also. A total T4 is preferred here, but please don't wait for an ultrasound or a technetium scan report to start thyroxine. Yes, so in this child also, we would have started levothyroxine ASAP. The dose is higher. The confirmatory test, as I just mentioned, needs to be sent. But again, they are not to be, you don't have to wait for all these confirmatory tests. A word of caution, whenever you have a suspected congenital hypothyroidism, a child with congenital hypothyroidism, please continue levothyroxine uninterrupted till 3 years of age. This is the period of maximum vein growth. The the dosage gets titrated based on the thyroid function test and can be done by a referral center. And important to monitor the growth in addition to thyroid function test. So a few quick googlies where we encountered thyroid dysfunction. This was a child who had alopecia and was referred to us with a borderline report of TSH. When we worked her up, we found out that with time, she had developed profound hypothyroidism. And with this alopecia, when we screened, she actually also had a problem in the gonadal axis. So she was a case of autoimmune polyglandular syndrome and not just alopecia with thyroid disorder. So again, pointers where 1 plus 1 is actually sometimes not just adding to 2, but may add up to 3. This child, if as a textbook picture we can recognize, she also came with a thyroid borderline elevated of, say, I think 9.9 or 10. If we can look at examination, she was 12 years old and she was also very short. She has a shield like chest and she has a little minimally increased carrying angle. So she was also a case of Turner syndrome who got detected because she was tested for short stature with a borderline TSH, right? And this one was a child who presented with recurrent diarrhea. And when we examined the child had a very bad rash. So that is when we started investigating and found that that diarrhea was actually a malabsorption diarrhea. And this was a case of celiac disease with these skin reactions. She also came to our center for a abnormal thyroid report with diarrhea, recurrent diarrhea. So please remember, sometimes errors could be beyond just missing these cases. It could be as simple as missing writing the correct units or interpreting it based on the unit. So please don't never get into the habit of interpreting a value of FT4. Please see the unit and the range and examine for physical cues. Sometimes they tell a story which is a bigger story than just that thyroid report. So this slide would summarize my approach of detection of abnormalities of thyroid in children. Pay importance to growth clues in terms of slow growth or delayed puberty. Any delayed developmental milestones, please be alert. Sometimes abnormal thyroid function may be an association, if not the cause. Dysmorphism have to be checked in all children, so it may take some time for you to detect. But any child who does not look to, which does not resemble the parents, should be referred. It is easier to refer to a center where they can detect and probably arrange for further workup. Associated autoimmune diseases have to be looked for. Goiter should be checked even in children. And Dr. Alpesh already covered central hypothyroidism. Thyroidism. We do also see them in children. And a word on hyperthyroidism, where they would present with thyroid crisis in terms of cardiac instability or eye signs. Right. So with this, I think I can stop my slide, ma'am, and I think we can have some. Yeah, I'll just stop.
Thank you so much, ma'am.
Thank you.
Moving on,
Uh,
we have our next. Yes, ma'am.
Shreya, Ashima and Dr. Alpesh, you're staying back. I'll just take 10 minutes.
Yes,
Also,
ma'am.
you both have covered that part. I will just quickly recapitulate, just a minute. You have to stop, Shreya.
Okay, ma'am. Okay, ma'am. We are stopping. Share the screen. Yes. Yes, ma'am.
Okay, I'll quickly, it would be more or less of a recapitulation now. You know all the thyroid diseases and drugs used, commonly used drugs in thyroid disorders: levothyroxine, leothyronine, propylthyroxine, methimazole, and radioactive iodine. These are the major drugs that we use. I will not go into the, okay, maybe I can do this. What is the difference between levothyroxine and leothyronine? Both are synthetic hormones. Levothyroxine is T4 synthetic and leothyronine is T3 synthetic. The hormone type is inactive. The onset of action of levothyroxine is slow, whereas leothyronine is rapid, and half-life of T4 is 7 days, whereas it is one day. So therefore you need multiple times doses per day for leothyronine, whereas levothyroxine can be given once daily. So that is why, because it is more stable, it leads to stable replacement, and it is given once daily. Levothyroxine is preferred in the management of standard hypothyroidism. Leothyronine is only used for refractory cases and in emergency where you need immediate action. But expect greater fluctuations with this. The pharmacokinetics of levothyroxine are little special. We need to be taking care of it for effective management. Although the absorption is good, but there is a lot of interference by food, calcium, iron, other drugs that the patient, it needs an acidic pH. That is why it is always, we are saying that levothyroxine should be given empty stomach at least 60 minutes before the patient takes the meals or food. Distribution is highly protein bound. So in pregnancy, there are a lot of changes in physiological changes. The proteins, volume of distribution, all these things change. So that is why there is a need for readjustment. Metabolism mainly metabolized by hepatic and peripheral conversion to T3 hormone. So drugs interfering with the metabolism here would be the enzyme inducers. So I'll come to that. Why do you need to readjust the dose when the patient is taking other concomitant medicines? Elimination is mainly by the renal and fecal route. So as I said, levothyroxine half-life is 7 days. Steady state is reached in 6 weeks. So don't expect that today you start medicine with levothyroxine, and many of us start measuring the thyroid function test, T3, T4, TSH, too soon. So since a steady state takes 6 weeks to reach, so it would be unwise to repeat these tests very frequently here. So at least 6 to 8 weeks time is required. And one more thing, that levothyroxine has a narrow therapeutic index. That means the difference between the safe dose, effective clinical dose, and the dose at which the adverse effect or the over replacement effect are seen, this gap is smaller here. So that is why we call it narrow therapeutic index. So that is why the you need to be very careful when you are increasing the dose of levothyroxine if the patient is not responding well. So a large increase in the dose can lead to the toxic or the side effect, signs of over replacement here. Then another very specific feature seen with very few handful of medicines are the variable bioavailability across brands. Uh, Levothyroxine is one of them. Phenytoin is another. Lithium is another drug where we have to be consistent with the brands here. If you change the brand, the bioavailability will be changing. So this may either lead to over treatment or under replacement here. So we need to measure the impact of change in the brand 6 to 8 weeks later, and adjust the dose of the patient. So but by and large, if we need to instruct the patient that be consistent with the brand, or they buy it from one company only. But this may happen in government supplies, where every year there is a new tender, so there may be a new manufacturer here. So that may be inevitable. But then whenever such changes happen in the supplies, you have to be really careful about this. Then interference by food, antacids, calcium, iron supplements. So the dictum here, I think the one thing that we can remember is that if all these antacid, iron supplements, coffee, tea, the drugs that which are interfering with the absorption of levothyroxine should be separated by at least 4 hours. Then we need to adjust the dose according to the age. And it is weight based. Ashima has already described. And pregnancy, you need to readjust, and comorbidities which need to be. So that means you need to individualize titration and TSH monitoring in these patients. So amongst the drugs which are used for uh, anti-thyroid drugs, methimazole has a longer half-life. whereas profile thyroid PTU has a shorter half-life, so you need to give multiple daily doses, but it is preferred in pregnancy first trimester, and it is also metabolized by hepatic route, so risk of hepatotoxicity is there, so we need to be careful about this. We need to monitor CBC, liver function test, and thyroid levels with patients taking on these medicines. Now, there are many comorbidities that may influence the thyroxine dose, which will need adjustment in the dose. Out of these are cardiovascular diseases. You have to lower the initial dose because sensitivity increases. There may be a risk of angina, arrhythmia. So start slow and titrate slow in this patient. Obese patient, impact on the dose is variable. So you have to should use lean body mass for dosing. For pregnancy, dose requirement is increasing, increased TBG levels. So there may be a fall in T4. So you need to increase the dose by 30 to 50% and monitor TSH levels. GI disorders, celiac disease, decreases absorption, H. pylori infection, then these CKD, liver disease, diabetes, CKD, the effect is variable, so you need to monitor carefully. And liver disease may require a dose change because these drugs are metabolized by hepatic route. Diabetes, the effect is indirect, but you need to monitor glycemic control during titrations. Some patient may switch to hyperglycemia side. And then central hypothyroidism, TSH is unreliable, so you need to guide, as Dr. Alpesh was emphasizing, that the dose should be guided by free T4, not TSH in central hypothyroidism. Now you understand the reason, why you need to, because of the influence of these diseases. And of course, elderly, as I said, start low, risk of cardiac events is there. Pediatric patient, not only that you start with the weight-based dosing, you need to monitor growth from time to time and adjust the dose accordingly. It is not that you start with the one dose and maintain that. It has to be according to the growth monitoring also. Coming to the drug interactions, iron, proton pump inhibitors, pantoprazole. Many of these elderly adult patients may be also taking proton pump, omeprazole, pantoprazole. But they can reduce the absorption. So best would be to space these medicines. Amongst the drug which influence the hepatic.
ड्रॉयर है ना मेरा ड्रॉयर
रंजीत, अपना म्यूट कर लो। रंजीत,
बस यहाँ आती है होटल है अबे डायरेक्ट होटल जाती है हाँ मेरे को नहीं दे रहा है अब ये बताओ एक ही फाइल को भेजना है कि दोनों को भेजना है दोनों को भेज दें
डॉक्टर रंजीत,
निमिष और
आई थिंक इज
निमिष और
Dr. Ranjit, can you mute here? This thing. Then rifampicin, these anti-epileptic drugs, anti-tubercular drugs can interfere. Hormones, estrogens, corticosteroids. So separate administration by 4 hours when possible is the answer to this. Now monitoring, is required. TSH and free T4 as and when according to the indication. At least it should be repeated after 60 to 8 weeks, particularly after any change in condition, weight, the status, pregnancy status, or formulation or a dose of the too early changes are not desirable because the steady state is reached after only 6 weeks of new dose, new formulation. So, and also when you are monitoring, don't forget the clinical symptoms. Just don't go by the labs here, lab values here. So clinical symptoms can also be used to guide titration. So judgment is also important. I always say don't treat numbers here. Don't just treat lab values, look at the patient as well. Symptom resolution is the key. I think in the question and answer session, we have both the experts here. We can talk about how which symptoms can be used to see whether the resolution is there. Then consider adherence. Whenever you find that the patient is not responding, lab values are not improving, think about the adherence issue. That should be there. Dr. Alpesh said already. And brand consistency and comorbidities. Then if you have to split the tablets, sometimes for children, the appropriate dose may not be available. But then here, because these tablets are coated, stability is an issue. When you split them, the coating is destroyed. This may affect the potency of the drug. So please check on this. This is true for other enteric coated or extended release preparation also. You cannot crush all of them. Just look at the package insert, whether you can crush these tablets or not. If you can, then go ahead, if it is a plain preparation. But if it is coated, you have to follow the manufacturer's instructions to this. If splitting is unavoidable, it is better to use core tablets. They have a line like this, so this will help in making two equal portions when you split, or use a pill cutter instead of a hand for accuracy, and split only right before use, not in advance, and avoid splitting very low dose tablets. As Ashima said, 12, sometimes the dose may have to be increased, or the dose is only 12.5, or then you have to don't split these tablets, because this will not be variation will bring about a significant impact on the symptom control. Other alternatives you look for, you go for a higher or lower depending on the clinical condition, use alternate doses, or switch to liquid or soft gel formulation. Now anyway, this is not only for the levothyroxine. This is whenever you are choosing preparation, measuring the dose for children, never use kitchen spoons to measure medications. These spoons are of different sizes and can vary from 3 ml to 7 ml. And levothyroxine being the narrow therapeutic index drug, it can lead to toxicity. Always try and use cups or oral syringes are better. If you have to measure 2.5 quantities which are below 2.5 ml, then the syringes are better, or you can use dropper, calibrated spoon, etc. So I think I have already said this. The key here is that for diagnosis, first the diagnosis should be correct. If you have made the correct diagnosis, then the treatment is easier. Then you need to just to follow the standard treatment guidelines, which prescribe the stepwise management for these patients, how to tackle the clinical issues that come across, and it will help in reducing the variation in practice, improve patient outcomes and quality improvement. This is one of the requirement for NQAS assessment, NABH assessment, that the facility, they are using standard treatment options. So healthcare providers get benefited because they can now concentrate on the diagnosis. If the diagnosis is correct, rest is going to fall in line. And of course, then by following the adhering to standard treatment guideline, you are adhering to the laws, policies, and definitely it would be a safer practice. I think I'll stop here. Now we can take up the questions. Two of our experts are here. I already saw there are a few questions earlier. Meanwhile, you can start writing your questions in the chat box.
Ma'am, I think there was one question on for Dr. Alpesh. I think that needs to be clarified
Yes, ma'am.
very clearly of stopping or continuing medications
Yeah.
once a hyperthyroid is now with normal thyroid. Dr. Alpesh, you want to take that first?
Yes, ma'am. So whenever we are treating hypothyroidism and we are achieving normal thyroid functions, so that's our goal actually. So we are achieving that goal on that prescribed strength of the tablet. So we actually need to continue that tablet in the same strength and not stop it. So that's a misconception that is often prevalent. That can we decrease the dose or can we stop it altogether? So that's not advisable. You continue the same strength.
It is normal because you are replacing it. Otherwise, it wouldn't have come to normal. And that is true even for hypertension. Many people think once their BP is controlled, they can stop their medicines. But it is, don't forget that it is with the medicines that the condition is controlled here. Next, overt hypothyroidism. TSH more than 100. How much dose altroxin to start in a patient age 65 years?
Okay, so I shall take it, ma'am.
Yeah,
Uh,
please.
yeah. So I think the principle of treatment remains the same. This person has severe overt hypothyroidism, requires the full replacement dose, but given the age and potential comorbidities, you will start with a lower dose and gradually up titrate it. So it's a good idea to start with a dose of say 25 micrograms, and then gradually over every 2 to 4 weeks you can increase the dose uh, to the desired dose, which is between 1.6 to 1.8 micrograms per kg body weight.
Dr. Alpesh, even I also have one question here. Sometimes can you use clinical symptoms, whether, teach the patient also, learn how to, monitor themselves, whether they are in, they need to change their dose or see their doctor. Sometimes symptoms continue or they develop symptoms of over replacement. What are those,
Ma'am, in clinical practice or as per standard advisory, clinical symptoms cannot be used as guidance to titrate levothyroxine treatment. Unfortunately, clinical signs and symptoms are neither sensitive nor specific for diagnosis of hypothyroidism. So, the fatigue, weight gain, these kind of symptoms, they can come from so many other elements that an individual may harbor alongside hypothyroidism. So if a person is having normal TSH levels and still having persistent symptoms, possibly patient is biochemically euthyroid. There are there are some data to suggest that there may be some role of leothyronin therapy in these individuals, but these are only 5 to 10% of all cases, and in such cases also therapy needs to be very much individualized.
Okay, okay, but do you find correlation between the lab values and the clinical symptoms improvement?
Yeah,
How?
that does happen, especially in severe hypothyroidism. So as madam also said that somebody is having TSH of 8 and attributing all her life's problem to that TSH of 8, that is not justifiable. But somebody is having a TSH of more than 100, you could expect that they would lose about they could lose weight of about 4 to 5 kgs or about 8 to 10% body weight they can lose after starting levothyroxine treatment. Their symptoms of fatigue, dryness of skin, those symptoms will improve. But many a times we get reference saying that TSH is 8, patient is having menorrhagia, having so many other symptoms. So these are not possibly attributable. While we may treat her mild hypothyroidism, but we have to indicate to the gynecologist that those symptoms may not be explained by her mild TSH elevation.
Okay. So either way, you have to look at the clinical symptoms as well. Either you find an explanation in the thyroid dose or any other comorbid illness. So don't forget, just don't depend on the lab values. Okay, what is the maximum dose of LT at PHC level that can be prescribed?
I think there is no such advisory as to what dose can be prescribed at primary level or tertiary care level. You can, whatever dose is suitable for your patient and you are comfortable treating that patient, that should be prescribed. If patient is getting controlled at a dose of say 125 micrograms, that's good enough. Only thing that we should remember is that if you are exceeding a dose of 2.5 micrograms per kg body weight, TSH is not getting controlled, then this you are into a territory of treatment resistant hypothyroidism, and these cases require a more detailed or more nuanced approach. uh, I have already emphasized that looking at adherence, looking at technical issues is very important, but in some of these scenarios a referral is not a bad idea, because some of these cases will also require a test which is called as levothyroxine absorption test, that we perform to see whether the patient is having a true malabsorption or a pseudo malabsorption. So if there is true malabsorption, we give 10 micrograms per kg, and then we see free T4 levels over next 5 hours. So if free T4 levels are not rising, that means a tablet is not getting absorbed. If free T4 levels are rising, that means that malabsorption as an etiology of hypothyroid, as an etiology of treatment resistant hypothyroidism has been excluded. And then we can again confront the patient with the same set of lab tests. Sometimes patients come up with their adherence issues more often when we show them the data or show them the evidence that these tests is showing that your blood levels are going up, so there is no major issue with the absorption.
Would brand change help in such patients?
Ma'am, changing we don't suggest changing brand
Because of the malabsorption, if you find that one.
Yeah. If there is lactose malabsorption, then there are certain brands which contain lactose as an excipient. Some levothyroxine brands contain lactose as an excipient. So if you are having lactose malabsorption issues, then in those cases you choose a brand which does not contain lactose, and the problem of treatment resistant hypothyroidism will settle.
This is, I think, related question. Foods that are avoided in hypothyroidism.
Ma'am, Ashima ma'am, you would like to address this?
Yeah, so nothing is to be avoided in hypothyroidism, but yes, iodine still has to be like it has to be iodized salt intake wherever can be recommended. No food, so cabbage, cauliflower, all these are known goitrogens, but again, in the amount of food that you would want them to take, it is all allowed. Especially in children, we don't advise any restrictions of food because each element, even selenium, is going to be important in some amount. So, no food restrictions at all. But yes, what we would want to avoid is outside use of those coloring agents, etc., which these days children do eat a lot, where they, I mean, use a lot of
Junk
use of
food.
food preservatives. Yes, ma'am, chemicals and food preservatives to color foods, etc. These could actually be goitrogens, and but they are like, we may not be able to pin them down with names, but they are known endocrine disruptors which should be avoided. So fatty food and oily food, I mean, this is then you're talking of a balanced diet, Dr. Maria. Yes, we are promoting a balanced diet, and the earliest change we actually see once we start children on corrective therapy in terms of treatment response in childhood hypothyroidism is improvement in their growth. So growth monitoring is very, very important. You can use any free to download Indian growth velocity monitoring apps or growth charts, but do monitor growth. Yeah. Thank you.
What is the future of Hashimoto's thyroiditis with fluctuating results and severe weight gain?
So I think, I mean, again, fluctuating TSH in a patient with Hashimoto's thyroiditis, it can be broken down into multiple causes. So one could be that disease is evolving. So you're requiring an increasing dose of thyroxine. So that person can give you a progressively higher TSH. So that will be, in fact, a increase in TSH despite increasing the doses till such time they achieve the final dose. Other causes of fluctuating TSH could be on our part as clinicians. We are at times very fidgety in changing doses of thyroxine. So changing doses of, so say 25 micrograms each time when TSH just goes from normal to 8.9. So this patient was missing some tablets, and now we have increased the thyroxine dose by 25 microgram. patient comes back, takes the tablet more adherently this time, and now TSH goes to suppressed range. So many times these fluctuating TSH issues are iatrogenic. We tend to overcorrect without taking into account the issues of adherence, issues of PPI use. Sometimes patients have an intercurrent illness, they would use PPIs in those times, or they would get admitted at that time, they would miss some tablets, they would use additional medications that would interfere with thyroxine absorption. So it is best that if such a history is present, best not to tinker with the stable thyroxine doses. So that could be very important in avoiding fluctuating results.
What is the take home message that both of you would like to give to the audience, because there are no questions, more questions, but something from your end that you want them, that you clinically see, and the take home message for the participants here.
Okay. So I think thyroid problems are common, and a basic understanding of thyroid physiology, thyroid function test is important to interpret the problem at hand. It's also important to understand the lab, how the lab performs, how which tests we are using. For example, both me and Madam have highlighted that free T3 is something that we should not be very relying upon. So important to understand the context, the clinical context, the biochemical interpretation, and then appropriate treatment in line with the standard guidance. That is the key.
Ashima, would you like to?
Yes, ma'am. So for all those who have access to at delivery points, so pediatricians, gynecologists, even people who are seeing young children, please emphasize for universal newborn screening for thyroid. So other disorders, those fancy 60 test, 50 test disorders on DBS is not what we would want to promote, because all these are disorders which have their own life cycle. But missing thyroid disorder at birth these days is sinister. So please emphasize for universal newborn screening, wherever place you are possible. You don't need a hi-fi DBS. A cord blood sample can do equally good as much as a DBS. So my message is only for universal cord blood screening.
Any particular time when the screening?
Either cord blood is at birth, where you take the sample from the cord, or after 48 hours of birth. So even those who, if there is a baby who has been born and the cord blood sample was not taken, there is no access to these hi-fi DBS things. People working in peripheral health centers or district hospitals, before you're discharging the child at 48 hours, please take a venous sample and send for normal thyroid function. Thyroid function test is easy on only TSH. I'm not even asking for a whole profile. Only a TSH which does not cost more than 100 to 150 rupees, even in the most rural area. So, and is easily available. So either do it at birth or do it after 48 hours of life. So either cord blood or after 48 hours of life, but mandatory TSH at birth.
Okay. Then any other time periods when they can do it if it hasn't been done?
So ma'am, any time when the child has come to you for even for the first vaccination.
Okay.
For pediatricians, if there has been no newborn screening done at birth and the child has now come to you for first vaccination at 6 weeks, even then a simple TSH can be measured. It is still only 6 weeks gone. We can still, like, we've not lost the entire life. It's just 6 weeks. We are just 6 weeks late. So it is never late. Never late than never is what we would emphasize.
And it is very important to give levothyroxine to this child, because for the growth,
Yes.
Otherwise brain growth, mental growth will not happen. So many myths are there, दवाई नहीं देना चाहिए, गर्म होता है. There are natural, other products, which can replace this. What are your experiences about this?
So, ma'am, usually in congenital hypothyroidism, at least those who are detecting on newborn screening, we don't face those problems. We do sadly still see children at 8 years of age, 6 years of age, 2 years of age with developmental concerns, short stature, who are missed congenital hypothyroidism. But my only message, that was just one of those unfortunate cases which happened in COVID, where even after diagnosis, she missed the doses. But yes, compliance is an issue. So Dr. Alpesh would agree. Even for childhood, well, this is going to be lifelong. So for a girl child who gets detected with Hashimoto's at 8 years or 10 years, what I tell the family, please don't stop the thyroxine when you're about to marry the child at 18 or 20. Because उनके लिए लगता है थायराइड है तो शादी भी नहीं होगा हमारे बच्चे का. And the first expression is, हम बंद नहीं करेंगे, will this not stop? So the disease is the same. You don't stop thyroxine when she's 18 or 20 or 24. So that those messages have to go. But yes, coming back to your question, I think what we also emphasize in these children is the need to continue therapy for attainment of normal brain function. And we have children of congenital hypothyroidism who were treated in time, and there is no difference. They are just normal in every other way, like an other normal healthy child.
So
So
we
those
need to
success stories have to be
emphasize,
shared.
yeah,
Yes, ma'am.
success stories, where the children have grown as normal adults with normal intelligence and growth,
Yes, ma'am.
is very important. And, there are, this happens with our neuropsychiatry illnesses also. वो शादी करने के पहले बताते नहीं हैं, and then they stop medicines and they come back with relapse, and then it becomes very difficult. Marriage भी टूट जाती है और patient भी deteriorate हो जाता है इधर. I think we have answered the question. There was one more question. Could you see, Ashima? There was one question.
एक
I think
question.
we had answered all fatty and
नहीं वो आपने कर दिया था
with hypothyroidism. Other
Stress.
comorbidities.
other comorbidities with hypothyroidism.
Yep.
Related other, I think.
I think, ma'am, this we have covered that if you have autoimmune hypothyroidism, you can have different autoimmune manifestations like for type 1 diabetes can have autoimmune hypothyroidism. You can have alopecia, madam had shown autoimmune alopecia. You can have autoimmune euphoritis. So many other as part of autoimmune polyglandular syndrome, you can have many other concomitant autoimmune conditions. And but autoimmune hypothyroidism remains the most common form of autoimmune organopathies that we see. Other than that, hypothyroidism related comorbidities, we don't hypothyroidism per se doesn't cause any other comorbidities if it is treated well in time.
I think so. Any in general advice for these patients who have other autoimmune illnesses?
So, ma'am, our major experience remains with type 1 diabetes. So, what we do in type 1 diabetes is that apart from their monitoring of growth in type 1 diabetes children, monitoring of growth and pubertal status alongside glycemic management, we also tend to screen them for celiac disease. At least during first 5 years of their diagnosis, they are at highest risk. So, we screen them at least once that time, and also we screen for TSH and thyroid peroxidase antibody at baseline, and then it should be done at periodic intervals. Some guidelines suggest that it can be done every 1 to 2 yearly. So, but we generally perform it as an annual screen. When we are screening them for other like annual workup, we include TSH at least.
I think
There is one more question for adult hypothyroidism where TSH is high every time and T3, T4 are normal. So is something to increase the doses. So I think something which Sangeeta ma'am had covered in her talk, where we are chasing a TSH which will take time to normalize, and if we have achieved the normal T4, then need not increase the doses but work on compliance and other errors that can happen in terms of drug dose, brand, breaking tablets, missing dosing. So all those could lead. I hope that has answered this question. And so I think I don't see.
I think
Okay,
we have
so how frequently a person can check for thyroid profile? I think now these questions are going overboard.
six. Thyroid in a patient who is on levothyroxine 6 to 8 after 6 to 8 weeks, they have to change. What else?
Yeah. Once I think once you have initiated the dose or you have made a dose change, it can be 6 to 8 weeks, but subsequently it can be 3 months. And once you have reached a stable dose and you have had normal TSH on 2 occasions, you can increase the interval to 6 to 12 months. Many of my patients, they are now on annual TSH screening because they have had stable TSH for a long period of time. So it can vary depending on from 6 weeks to 1 year actually.
What is the role of giving supplements like Thyrowell plus tablet on hypothyroidism?
So
I
that
don't know this
that tablet actually contains selenium, I believe. There is, see, the data for selenium has to be interpreted very cautiously. So the data, if it is generated in a selenium deficient region, may not stand true for a country like India, where the selenium there may not be selenium deficiency. And selenium per se has not been shown to have much role in hypothyroidism. Only it has shown some role in mild thyroid eye disease, where it's been used in Graves' orbitopathy, that too mild disease. And that data also comes from Europe, where there was that the study was performed in a selenium deficient region. So there is no evidence to support the use for selenium.
I think the take-home message is levothyroxine alone will be able to take care of 99% of the patients. You know, so don't bother about 1%. If you come across such patients, refer them to Dr. Alpesh Goyal. Now you know him.
Yes, ma'am.
I think we can now close. There has been a post test in the chat box. You can start doing that. Feedback link is also there. There is a video recording will be available after about 7 to 10 days on YouTube channel of Quality and Patient Safety Division of NHSRC. You can even see the previous sessions, videos of previous sessions on the YouTube channel. And we look forward to you for the next session. Next session is on antimicrobial use and antimicrobial stewardship. I think happy Chhat Puja. We should have wished you all Diwali, but anyway, all days are Diwalis here, so we wish you a happy holidays.
Thank you, ma'am.
so
Thank
much,
you,
ma'am.
NHSRC.
Thank you, Alpesh. Thank you,
ma'am.
Ashima, for joining us. Thank you for staying with us throughout the session.
Thank you so
Thank
much.
you so much. Thank you so much, everyone.
Thank you.
Okay.